Good afternoon. I'm Marion Mulkey. I am with the California HealthCare Foundation, an independent philanthropy based in Oakland that works to advance ideas and innovations that improve healthcare for all Californians. I'm delighted to be here and really pleased to have a terrific panel. I have been reflecting as the day has gone on, and we've heard about the political outlook in Washington and some of the other issues that over the years that I've been involved in conferences that look at state-federal dynamics, there have been many times when those of us from California have been sort of hanging our heads about, say, the size of our state budget deficit or some of the specific political issues that we have here. I think that today in this lineup, we can feel pretty good about ourselves here in California in terms of where we stand with respect to the implementation of the Affordable Care Act. As you're going to hear from our speakers, I'm sure, California was very early out the gate in making many decisions around implementing the Affordable Care Act. There has been a great deal of activity and cooperation between our legislature and our administration, and there have been some really tangible signs of progress in California reflected in our enrollment numbers and in on both the public and private side, and in many aspects of the decisions I think that have been made so far. Nevertheless, you also hear in Sacramento these days that California looks good partly because we're grading on a pretty steep curve. And so I think we all know that there's still work to be done and room for improvement. And I think we're going to hear some terrific insights from this panel today on both where California stands today and on where we have the potential to go in the next year or two. So I'm going to give you a rundown on the panelists all at once. I'm going to be very brief on their biographies because I'm one of those people who just kind of cringes about reading through the big long list. But their many accomplishments and deep expertise is reflected in the biography in your books, so please study them at your leisure. So the lineup that we're going to go with today is going to start with Gina Boscarino, who's Senior Policy Director at Breakaway Policy, who's going to give us sort of a national viewpoint. We're then going to move to Toby Douglas, who's the Director of California's Department of Healthcare Services, charged with implementing all aspects of our state Medicaid program, Medi-Cal. Then to David Maxwell Jolly, who's played an enormous role in the establishment of California's marketplace, covered California, and particularly the IT systems there. And conclude in the formal remarks with Juan Davila, Executive Vice President of Healthcare Quality and Affordability at Blue Shield of California. And we are going to do our best with this panel to leave some time for conversation at the end among us and responses to your questions. So that's our plan of our approach, and we'll start with Gina.
Thank you. Very nice introduction. Pleasure to be here. This is, unlike everyone else here, this is my first year here. So heard from my colleague, Dean Rosen, who has apparently been here just about every year this conference has occurred, but this is my first year, so happy to be here. What I'm going to focus on today is really some kind of hardcore numbers on the exchanges. And really it's sort of like, a little bit like John's numbers for the employer market, but obviously we are talking about a much smaller market at this point with the exchanges. But we think that what we have done, and I'll get into this in some detail at Breakaway, is put together a database, a very detailed database of cost sharing and benefit design, premium information for plans in all 50 state marketplaces. So the reason we think that this is important is that the employer, we have all this information on the employer market. We realize this is a separate, smaller market. However, it really raises the question as to whether some of the cost sharing, the benefit design that we see in these new exchanges will eventually migrate, make its way into the employer market and into the private exchanges. So that we think that although the information that we are putting together here on the exchange market is limited at this point, maybe not in the next year, but 5 years down the road, these could be indicators as to where the employer market ultimately ends up. And what we've done is taken a look at a cut of our data, looking at how California, its benefit designs, cost sharing compares to the rest of the nation. So let me go on here. Okay, before I get to the data, I want, though, to take a look at some of the areas where we could really look at California and say that they are, ahead of the curve. Let me do those first slides here. And one of those is on exchange competition. California, we're looking at 11 carriers participating. And when you compare California to, and although these are smaller states, Kentucky and Rhode Island, which are both regarded as state-based exchanges that had relatively successful launches, like California, they're looking at 3 carriers and 2 carriers, respectively. So California does seem ahead of the curve on a number of carriers. And nationwide, even beyond those states, there are concerns regarding competition, number of carriers and markets. This is different, though, than, and not to take away from the fact that California has a good competition base here, the narrow network question that came up this morning. So while the competition is definitely there, California does still face the issues with narrow networks that were alluded to this morning. And I think it was John who mentioned this morning that in looking out there at the market, it's looking a lot like 1994 again in terms of plan designs. And one of those plan designs is the use of narrow networks. So that is a challenge that California is going to face along with all the other all the other states basically. So let's see here. Another area where California is ahead of the curve is in health plan ratings, and just recently decided to display the quality ratings and data about their participating plans. The ACA requirement is that that data does not have to be posted until 2016, and most states are waiting for federal guidelines on posting the quality ratings about the plans on the exchanges. But California is a little bit ahead of the curve on that and have already began posting ratings based on member experiences. It's a star rating system. And there are a number of states, and I have those listed there: Connecticut, Colorado, Maryland, Minnesota, New York, Oregon, Utah, Vermont, and Washington that are joining California. But otherwise, they're kind of ahead of the group there. Now, there are also areas in which California is facing some challenges. One is with the online physician directory, and this has been a recent issue. However, I think, that this is an issue that predates Affordable Care Act. So, this is not necessarily something that is new, but you can see where this could become an issue with the whole question of the narrow networks. And it kind of exacerbates that problem where if people are already having a problem finding a network where they have a physician or a hospital, and then they're not exactly sure whether that physician or hospital is in the network, then that can, kind of exacerbate that whole problem. Okay. I'm going to start moving into the data that we have gathered at Breakaway on the state-based or on the exchange plans. What I've started with here is a snapshot of standardized plans, and for some reason, some kind of feature on there that isn't working. But let me move on to the next slide. Oh, there we go. 6 state-based exchanges, including California, have standardized plans, meaning cost sharing is standardized across the board for plans. And in most of those states, they also allow carriers to offer some non-standardized plans. But why I have included this is to give us an idea of what the cost sharing is in these states with standardized plans. And if you look at California, they're pretty much in line with the other states that have standardized benefits. So we're looking at deductibles in the area of $2,000 for individuals, which, as we noted this morning, is on the high side. When you look at the employer market, you're looking at about $1,100 is the average deductible. So already you're seeing these standardized benefit designs an edging up in cost sharing. which is, I think, what is one of the things that, as Dean pointed out this morning, that we saw right away, is that although, arguably premiums are lower in these new exchanges, the cost sharing in terms of deductibles, co-pays, out-of-pocket max have all edged up, and in some cases considerably. So let me move on. That's just to really give a context, and as we'll see a little bit later in some of the slides, when we look at where California is relative to the rest of the nation, sometimes they'll have California will have a copay or a deductible amount, and it's set as a standardized amount, and that's where the number comes from. So what we did was we looked at all 50 state marketplaces, and we focused on silver and bronze plans. Why? Because obviously people are going to be drawn to the plans with the lower premiums, and also the silver plans where they will get the cost sharing reductions. So we recorded the data for those plans. And as I mentioned before, we thought that this information was important, not only because it really shows what people are actually paying for benefits. Before the exchanges launched, there was so much focus on premiums. Everybody talked about premiums. But when you really think about what a benefit is costing individuals, there's so much more that goes into that. And that kind of is what gave us the idea to put together the database. So we took into consideration deductibles, out-of-pocket limits, and we looked at co-payments and co-insurance for prescription drugs and physician visits, inpatient hospital stays, emergency services. So we're looking at, the volume of data is enormous, but we thought it was important for people to have this. And also clients were asking about it. Pharmaceutical manufacturers, provider groups, before they enter a market, they really want to know, is there something in the cost-sharing plan designs in this market that will either encourage or discourage people from utilizing services? Okay, so when everybody was talking today about whether they had a slide that could be made into a placemat or put on, the refrigerator, and I was thinking, I don't know if this might be my slide that I would use. But this is just the typical map showing that, showing the states we looked at, federally facilitated versus state-based exchanges. Let's see. And now we're going to get into the data. What we decided to do for this presentation, and what we, with the database, we can take various cuts of data and make the comparisons we need to make. We looked at California versus the national marketplace, and also we wanted to compare California to another large state-based exchange, so we selected New York, and another large federally facilitated exchange, Florida. And actually, I think that the selections turned out to be telling, because as we look later on at some of the cost sharing, I don't know why those numbers are jumping. It's very distracting. Or I've got some kind of twitch now. I don't know. It's either one or the other. But one thing right off the bat here with the silver plan premiums is that, as we said before, that premiums are lower, and I knew that because when I first looked at this slide, I was like, oh my gosh, where's my employer-sponsored insurance average? And it didn't catch my eye because it is way up, it's higher than all the other averages that we looked at here, both for 27-year-olds and 50-year-olds. So the premiums are well below. But as you move on to deductibles, you see right away that we're looking at, and this may be, before I go any further, I know that there are some issues with the slides that were printed where the values did not show up as they do on there. You might just have it says value on there. We will post these slides on our website with those numbers in it so that you will have those. Okay, so looking at this, we're looking at deductibles that are, roughly twice what the employer-sponsored coverage is. And let me say something too about that. Employer-sponsored coverage, that's really not an apples-to-apples comparison, okay? But it is a comparison that people are making, that people are looking to, even though, it's really, you're making a little bit of a stretch to compare this individual exchange market with the employer market, but still it gives you some sense of, some basis of comparison. So in looking at the deductibles, the other point I want to make too is that we looked at medians, and the employer-sponsored market numbers are averages. But when you have a market that has so much variation in it, like these new exchanges, we thought that kind of throwing out the highs and lows made the data a little more, a more representative look at what we're looking at in terms of cost sharing here. Okay. Moving on to the primary care physician visits, median copays here, again, we're seeing these start to edge up. And what you'll see as we carry through here is California is a little bit above the average there, national average. Florida, which is a state-based or a federally facilitated exchange, in a state that was not really accepting of the Affordable Care Act, their numbers are pretty high, and you'll see that throughout the cost sharing. New York, also with standardized benefits, closer to the average. But one interesting thing to note, too, is that looking at these new exchanges is very complicated because there are so many variations on plan designs here that even just looking at the copay amounts doesn't tell the full story. Because, for example, one of the new plan designs that we've seen that doesn't seem to be as common in the employer market is this kind of copay coinsurance combo where I'll be looking at, let's say, $30 is your copay. That's what we have as an average. You will find plans, though, where, yes, $30 is your copay for your first 3 visits. And then after that, though, you're going to be paying coinsurance. Or your deductible does not apply for the first 3 visits, but then it does. So these kind of like variations on, what seems to be a simple copay is something that we really have to look behind some of these numbers, and that's what makes kind of analyzing these markets so complicated. So let me move on to specialist. Specialist visits, first of all, we're still seeing mostly copays in the area of specialists. However, we are seeing a little bit more migration toward coinsurance. So again, edging up cost sharing. Florida here is out ahead with 75. California is pretty much in line, a little bit over the national average, but still, still in there. New York has standardized benefits. This is kind of interesting. They have standardized benefits, but still, even though they have their copay is $50, or the 33% of New York plans are going to charge coinsurance. So that's significant too. So again, we're seeing a trend toward increased cost sharing for individuals. Inpatient hospital stays, that's always been an area where it's mostly coinsurance. What is interesting there, though, is that 63% of New York plans are charging co-payments for inpatient hospital stays. The reason for that is that's how it's standardized in New York. But again, Florida's out there at 30%, and California is coming in just a little bit over the national average, or the employer average, but below the national average. So their cost sharing is relatively low. Just before I move on to the prescription drugs, one point here on the takeaways is that, like California, I want to focus on the third point here. Most national silver plans charge co-payments for PCP and specialist visits. Although the data that I'm presenting here today is silver plan data, there is a significant difference between cost sharing in silver plans and bronze plans. So here, silver plans are more than twice as likely as bronze plans to charge co-pays for PCP. We're seeing a lot of coinsurance in the bronze plans, so cost sharing extremely high in bronze plans. Okay. Where we're getting a lot of questions from people are on the prescription drugs. Pharmaceutical manufacturers, and others are very interested in what is being charged for prescription drugs. Now, what might catch your eye here is that if you look at the generics, California, you might say, why is California double what the national average is? Well, California, unlike most of the other states out there, California does not subject their generic drugs to the deductible. So individuals are going to go and they're going to pay $19, whereas in some of these other states where $10 is the copay, that is the copay after someone meets what could be a relatively high deductible. So sometimes just looking at the numbers can be misleading. And when you look, though, when you move up in preferred brand, non-preferred brand, then California is a little bit more in line with the national average, which would make sense because those are the levels at which California does subject their drugs to the deductible. A little more in line there. Okay. Specialty drugs. Usually when we're dealing with specialty drugs, we're looking at coinsurance. Here, California is actually a little bit below the national average, so another area in which things are looking a little better in California. One thing that I do want to note, and this is one of the other slides where there was an issue coming up, median copays for plans where they're charging copays as opposed to coinsurance, very high. National average is $150. That number there, that $35, very low. It should be $80 on your slide, and that's the employer-sponsored insurance. But still, to look at that and see that plans are, charging $150 for copays, and that is most likely after an individual has to meet a deductible as well. So what we're looking at is that even before cost sharing kicks in for people in the exchange plans, there's going to be a significant outlay of funds where most people, are not used to having to meet such a high deductible before their cost share kicks in. Also, you're running into a situation where coinsurance amounts almost become irrelevant, where if you have a deductible that's so high and you have a narrow network, people are never going to meet their deductible to even get to a point where they're paying, a copayment. They're going to be paying out of pocket. And then you have a situation where you have an out-of-pocket max that's almost close to the deductible. So, these are really, these plans look very different from what's in the employer market. And although the premiums came in low, as was, promised by proponents of the Affordable Care Act, I think that even proponents of the Act might be a little surprised by, what we're seeing in terms of cost sharing. So I'm happy to answer questions later on about the data. And as I said, I will post these slides on our website at Breakaway so that you can get those numbers that did not show up here today. So, thank you.